Hi, and welcome to LCAL Low Carb Ancestral Living with Pim Johnson. Today, I have a very educated guest with me. Her name is Rowena Field, and she's a physiotherapist and has completed a PhD looking at how different macronutrients, nutrient density, removal of anti-nutrients, etc., can be used in chronic pain management. So that's what I thought that we would talk about today. She's also the director of STEP, Solutions, Tools and Education for Persistent Health in Australia. And she's here to talk about the impact of low carbohydrate diets on chronic pain. And I'm also hoping that I will be able to pick her brain a little bit about the placebo effect and perceived pain. So, welcome to the show, Rowena.
Thanks for having me. I'm keen to have a chat.
Awesome. So, you've been a physiotherapist for quite some time. How did you, like, all of a sudden
Oh,
develop an interest in diet to the degree that you wanted to go and get a PhD in that?
well, I guess it's sort of one of those stories where, it's personal experience, isn't it, that gets us interested in lots of things that we do. And I guess I was always a chubby teenager and struggled with my weight. And, I lived through the 80s and the low-fat aerobics era. Always something that I was interested in was diet because I was always trying to manage my own. And I guess I stumbled across keto and low carb diets maybe, I don't know, 8 or 10 years ago now. And it was such a different approach to what I thought was the correct way of eating that I got interested in it and obviously tried it for myself and worked effectively for helping me. And it intersected with my other role as a physio just because I also specialised in chronic pain again through personal experience. I had chronic pain and found that, the current knowledge around how to manage that within my own profession didn't answer very many questions for me, and so I did a lot of digging in trying to find out what was the new research in chronic pain, and I found there was lots of interesting intersections with things that they were talking about in the keto low carb space with the different mechanisms that are involved in managing inflammation and stuff like that, which were also the same mechanisms that they were very keen over here in the pain space to talk about as well, and what medication could we use to deal with that. And I was sort of in the middle going, hang on guys, we could there's some crossover here that we could look at, and that's where I got interested in this whole idea of, well, how does diet really potentially influence our physiology when we're trying to manage somebody's pain? I thought, well, there's probably got to be lots of research that's already been done out there. So I went and had a look, and funnily enough, there wasn't very much at all. And so I just because I guess I was at that point in my career and time in my life when my kids were sort of growing up and I could be a bit self-indulgent, and went back to uni and did a PhD looking at that specific topic.
Awesome. So can I just ask you, how did you find a PhD, or did you write a proposal and to someone that you thought might accept it, or how did you go about
Yeah,
that?
Yeah, that's what you've got to do. So you've got to come up with some sort of novel idea. So a PhD is really doing some research in a niche area that doesn't have that thing particularly looked at. So when I realised that nobody had looked at low carbohydrate diets and pain management specifically, I thought, that's something I'm really interested in. So yes, you have to write a proposal, and then find a supervisor at a uni that wants to take you. So it was a bit of a process going through different unis to try and find somebody that wanted to, you know, take a hedge a bet on a physio doing
Yeah.
dietary research. I had a few stumbles along the way with, there was one university that I enrolled at initially to do my PhD, and when they discovered what I really wanted to do, decided that physios shouldn't be talking about diet and promptly told me I had to do a different topic for my PhD. So I left there and went to Sydney Uni, which is where I did my undergrad degree as well, and found a supervisor there who had done some research in around sugar and low carb stuff. So he was already a little bit in that space already, and he's a little bit of a cowboy and likes to have some controversial stuff going. So he was prepared to take me on, and that's that's how I ended up doing a PhD with him.
Nice. Well, I'm glad you did, and that you didn't change your topic, because I can imagine a lot of people would be like, "Yeah, okay, since I'm here, I'll just do that then." And
Yeah, and I did think about doing that because they actually offered me a scholarship at the time to do it. And I thought, oh, do I want to give up a scholarship to,
Mm.
I could just do some other topic. And then when I'm finished, to go back and research what I wanted to do. And then I thought, yeah, no, I just want to, do what I'm interested in. So that's, I guess, a
Yeah.
bit of a luxury when you're older. If you go back and do that when you're an early career, researcher, you're sort of a bit more stuck in what your options might be.
Yeah. Good on you. I'm proud of you. I think it's great that you did that. So, can you just give us like a definition of what chronic pain is and how and why that appears?
Yeah,
Quite
sure.
broad
So
topic.
chronic pain is something, it's really not well understood, and there's a very big difference between acute pain and chronic pain. And even a lot of health professionals, I think, don't really understand the difference between the two. And mostly when you say to somebody, what do you think is chronic pain? And they'll say, oh, well, pain that's just been going for a long time. And that is certainly one of the definitions of chronic pain. It needs to have been sort of going for longer than 3 months or beyond the time when normal healing should have happened. But I think the really big difference between acute and chronic pain that people sort of lose sight of is the fact that with acute pain, there's been some sort of new tissue damage, like you've cut your skin or you've sprained your ankle or you've done something where some sort of tissue in the body has been damaged and now it needs to go through a healing process. And that acute pain is a protective mechanism to make you take notice and fix the problem and also allow it to do that healing, without being damaged further along the way. Now, the difference with chronic pain is that chronic pain is pain that is still going without any new tissue damage. So there was something back at the start that probably triggered or caused the pain initially, but now we're way down the track beyond the point where, things should be healed, and yet the person still has pain. And so what we know at that point is that pain the person's experiencing, it's a little bit about the stuff that was hurt in the first place in those structures, but it's a whole heap more about other things that are going on and other things that are driving that pain experience. And so really, if we're trying to help somebody with chronic pain, it's about looking at the bigger picture and looking at all of the other things that are involved now in that process. And that includes physical things, it includes metabolic stuff, how well you are, it includes psychological things, what you think is going on, experience, learning, knowledge, all sorts of things then come into that story. Because ultimately, what's happening is your brain is still, when it's trying to decide, am I safe or am I not safe? Is protection required? It's continuing to come up with the answer, yep, protection is still required. So let's give you some pain to try and manage that, even though there's not really any new tissue damage or any new structural reason why it necessarily needs to be going. So trying to treat somebody with chronic pain is a very different thing to treating somebody with an acute pain problem. And if you tend to try and treat chronic pain like it is acute pain, it usually makes the chronic pain problem worse. It ends up driving that problem and making it worse. So we really need to look at them as two separate things.
Okay. So, when you started doing your PhD and the research that you did you only look at a low carb diet, or did you have other groups of people doing other diets as well and comparing them, or how did you go about this?
So when you do a PhD, you've got to do some preparatory work to set the scene for why you're going to do the study that you're going to do. So part of the process for my PhD was going back and having a look at all of the published literature that exists for any sort of dietary intervention that is used for chronic pain. And so when we go back and actually have a look at what's out there, there's about 48 studies that were available when I did I think this is back in 2019 or 20 when I did the systematic review. There's about 48 different groups that use diet to try and manage a pain problem. And when we looked at the type of diets that get used there's all sorts of diets in that mix. There's everything from vegan, vegetarian, Mediterranean to elimination diets like gluten-free and stuff like that. So when you pool all those studies. So that's what we did, a meta-analysis, where you take the results of the ones that can be sort of put together to make like a mega study essentially, and try and come up with some more answers. When we did that to try and figure out, well, okay, which diet is best for chronic pain out of all of those ones that had been done. And out of all those ones that we did find, there was only one study that was actually using a low carb diet at the time. When you look at them, it really didn't matter too much which sort of diet you put anybody on. As long as you put them on a diet, they got some sort of significant pain improvement, which is sort of a bit of a head scratcher when you're at the start thinking, okay, well, this is crazy. That means any sort of, as long as you put somebody on a diet, it's going to help. But I think what you're doing when you put somebody on a diet as an intervention strategy for their pain, what you're doing essentially is you're cleaning up their diet a little bit. So you're more likely to be, cooking food for yourself, and you're less likely to be eating, takeaway and things like that. So it's got probably a little bit more to do with the quality of the diet and maybe improved nutrients that are coming in through the diet that are showing that sort of effect. So what we did then was say, okay, well, the diet that we're specifically interested in looking at is a low carbohydrate diet. And the reason why we're interested in looking at that is because there's all sorts of ways in which the nervous system physiology gets affected when you change the carbohydrate fat ratio in a diet. And so, again, another part of my PhD was then going back and doing a review of the literature, looking at, okay, how does a low carbohydrate diet impact the nervous system? And so there's a lot of preclinical studies, so rats and mice studies and things like that, looking at all of the, trying to flesh out, I guess, all the different mechanisms by which a low carbohydrate diet affects the nervous system. And there's all sorts of different things in there. And I'm sure your listeners have probably heard of a lot of those things, like, it improves mitochondrial function. It's an efficient energy source. It produces ketones, and those ketones are signaling molecules. And those signaling molecules affect the nervous system in a way that helps to settle down an overexcitable nervous system, which is the situation you've got when you've got chronic pain. So if you think about what chronic pain is, it's sensitization of a nervous system. And if we can use ketones to try and help improve that, then that sort of, it gives us some rationale as to why we would use a low carb diet as opposed to any other sort of dietary intervention that might be out there. And when you look at how chronic pain is managed, a lot of the type of medication gets used for chronic pain are anti-epileptic and anti-seizure drugs, which, when you stop to think about it, sort of makes sense, because what they're trying to do is they're trying to address the sensitization or the sensitivity within the nervous system as well. So a seizure that you might see in epilepsy is sort of like right up the end of the spectrum in terms of, excitability of the nervous system. But chronic pain is somewhere sort of along that a little bit as well. And so we know that chronic pain is improved by taking these medications. So our argument was sort of along the lines, well, we can change people's physiology by changing what they're eating rather than giving them opioid and other medication to try and do that. So you sort of have to build your story along the way as to why you would choose low carbohydrate diets as being the diet that we did choose for intervention. So I guess that's a long answer to your question. But yeah, we did look to see what other diets were available. We chose the low carbohydrate diet based on the evidence of what it would do in the system. And then when we actually ran our clinical trial, what we did was we did a randomized trial where we got everybody to do a run-in diet to begin with. And so that run-in diet was 3 weeks where everybody pulled out the ultra-processed food out of the diet. So we used the NOVA classification system, which is just a way of helping people understand, which foods are ultra-processed. So essentially they just had to pull out all of the chips and lollies and, discretionary foods that aren't great for you. So that's what everybody did to begin with for the first 3 weeks. Then after that, we randomized them either to continue doing that whole foods healthy diet or to do the same diet but actually make it low carb ketogenic as well. Because a lot of the criticism around dietary trials are that, okay, well, yes, you put them on a diet, but you also cleaned up their diet and you're comparing it to a Western diet. So we wanted to be able to say, okay, well, we've actually cleaned up everybody's diet here so that we can compare apples with apples, essentially, and be able to comment on both just, the potential pain improvements just from cleaning a diet up, as well as the potential improvements from also making that diet lower in carbohydrate. And I guess the interesting thing that came out of that research was that both groups did significantly improve their pain outcomes. So I guess one of the take-home messages for clinicians is that, even if all you can do is to get somebody to remove the ultra-processed food out of their diet and start to eat more whole, real food and cook for themselves and that sort of thing, that's at least a great starting point for pain management. Now, there were additional benefits for the ketogenic group. Their numbers in terms of pain improvement was a little bit better, but it wasn't significantly better than the other group. But they did have a lot of other things that they improved significantly on that the other group didn't. So they lost a significant amount of weight. Their inflammatory markers on blood testing improved, and their scores around depression and anxiety also improved as well. So there's still reason why you would, try and encourage somebody to take that a little bit further and trial a ketogenic diet as an intervention for their pain, because there's potentially other things that can improve as well. But that shouldn't stop people just trying to clean up their diet a little bit. If people don't want to go low carb, that's okay. You can still get some benefit from improving your dietary composition or the nutrients and stuff that you're getting in as well.
Interesting. So you mentioned that the ketones in themselves are doing a lot of things, and I'm wondering, could you actually just clean up your diet a bit and take some sort of exogenous ketones and get the same benefit?
I don't know. That would be a really interesting research project, wouldn't it? Because and a lot of the research, I guess, around exogenous ketones in the space of, like Parkinson's and Alzheimer's and those sorts of things are showing improvement. And that's in a population or a patient population that is really difficult to get them to comprehend and engage in a strict sort of ketogenic diet. So there is potential, I think, for exogenous ketones with pain management, but that study certainly hasn't been done at the moment, and it would be a really good one to do.
Are you going to do it?
I would like to. If somebody wants to fund it, that'd be great. That's the one thing about, diet trials and things like that. There's no money to be made by anybody in any of this. So there's no big pharma or, anybody that wants to dole out money to fund that sort of research, which it makes it hard because, when you go back and look at the research, it's, there's not that many, trials looking at whether diet's actually going to help somebody with chronic pain. So it probably doesn't work. Well, that's only just because there's been no money put in, no money available to do that research. It would probably show that there's a really great benefit in doing it, but the studies just haven't been done.
Yeah, for sure. So I'm wondering, what other things then ketones would be beneficial when you start a low carb diet with relation to chronic pain?
So if we think about ketones as a signaling molecule, there's quite a few different things that they do. If we want to sort of get down to the nitty-gritty a little bit.
Please do.
They act a little bit like a hormone. So as hormones they circulate, in your bloodstream, and they go to target organs and they do different things. So ketones also do that. So we talk about ketogenic diets, when we're in the obesity space or diabetes and things, and we're really thinking about ketones as being the fuel source. And certainly they are a fuel source as well. But it's this signaling side of what they do that is really exciting for neurological dysfunctions. And so if we think about what they do to the actual nervous system, they impact on the excitability, and we've sort of already hinted at this a little bit. But if you think about how our nervous system works, there's a dynamic range of how excitable a nerve should be, a nerve talking to the next nerve should be, and a whole network of nerves should be. Because if they get too excitable, then they fire off all the time when you don't want them to. Or if they're not excitable enough, then there's not enough to be able to make them fire when we need them to. So a lot of people are used to that term homeostasis, where everything has to be, there's a nice, happy level that everything's set at. So our temperature and our blood glucose levels and all those sorts of things, there's a nice zone where everything works the best if that's where that item is sitting at. And the excitability within the nervous system is the same. There's a set level that it should sort of sit in to make everything work well. Now, what tends to happen with chronic pain is that something goes a little bit wrong with that level of excitability. So we often hear the term like sensitization within the nervous system. So the nervous system gets upregulated or more sensitive than it should be, and it becomes this so the nervous system that's looking after the injured body part fires off too easily, giving danger information back to the brain for processing. So there's a problem within the excitability of the neuronal system as a whole. And what we know that ketones do is that they seem to, and there's lots of different ideas about how they actually do this, and this is where we get the information back from the mouse model studies and things like that, but they seem to do something to alter like the GABA to glutamate ratio in the brain. So that's the neurotransmitters, the balance between the inhibitory and the excitatory one. And there's a few different mechanisms by which it helps to improve that ratio. And they also seem to improve the redox balance. So that's improved the levels of oxidative stress within the nervous system. So they buffer that stress a little bit. And they seem to do that because they attach onto receptors, like G protein receptors on the nerve. And they also, there seems to be some sort of mechanism by which, so when ATP gets broken down, so most people know ATP is an energy molecule, and as those phosphates are broken off, that energy is released, and we end up with adenosine down at the end of that cycle. Now, adenosine is also something that is a signaling molecule and seems to help to regulate the nervous system excitability as well. And we know that ketones are a more efficient, fuel system. So you're getting more ATP essentially, which can then break down to adenosine. So there's lots of different reasons as to why the nervous system might be, or how the nervous system might be influenced by ketones. But I guess the overall explanation is that they seem to be what we call neuromodulatory and neuroprotective. So they do something to help modulate the nervous system back to its happy level and to protect the nerves and how they function. So that's sort of the first thing that ketones do. The next thing that they do is that they can help reduce inflammation, because what they do is they block the NLRP3 inflammasome. So it's sort of like the big upstream parent body inflammatory molecule, and there's a whole heap of different sorts of inflammatory cascades that come from this parent molecule, and ketones seem to be able to inhibit that. So it's quite a broad-ranging inflammatory control that the ketones seem to have. We also know that they signal around mitochondrial function. So they seem to improve how the mitochondria function, and they also seem to increase the numbers of mitochondria present in the neurons. And we also know that they regulate genes, so they're epigenetic regulators. So they inhibit, they're HDAC inhibitors is the technical term, and the genes that they inhibit, or the genes that they change, again seem to be around mitochondrial function and inflammation as well. So that's all sort of, I guess, a bit fairly complex, and I'm not sure that we all really understand how that functions, but ketones just seem to do something over that whole system that are beneficial to the nervous system. And I guess the flip side, so we've talked about ketones as well, but the flip side to this whole story is that not only are we producing ketones when we are doing a low carbohydrate diet, we are also reducing glucose. And that's something that sometimes gets forgotten about in this story as well. So just due to the fact that there's less glucose available in the system, even though we're not thinking about, the ketones being formed, for energy and stuff like that, the fact that there's less glucose means that there's less availability for that glucose molecule to attach itself or glycate to proteins. So we're fairly happy where we hear that, if you've got increased glucose, in the case of diabetes, it's attaching itself to, like the proteins in the blood and stopping oxygen carrying capacity and that sort of thing. But they don't only attach themselves to the proteins in the blood. Glucose will also attach itself to the proteins in your ligaments, your tendons, your cartilage in your joints, and the nerves. And whenever glucose attaches to a protein molecule, it just affects the way that protein works. And so we start to see damage in those tissues if you've got somebody that's got high glucose levels. And unfortunately, the poor diabetics tend to be a good example of this. So not only with diabetes do you have the obvious problems that we hear about, but also they're much more likely to have tendinitises and tendinopathies and things like that because of the damage of the high glucose load in the tendons. They're more likely also to have neuropathies or damage to the nerves for the same reason. So we know that too much glucose floating around in the system is not great for our soft tissues. So when you go on a low carbohydrate diet, by default, you're reducing the amount of sugar excursions that you've got going on in your blood, and you're going to improve potentially the quality of those other soft tissues that are really important when it comes to pain management.
Oh, you stole my next question, which was about glycation. So excellent.
Oh, sorry, I preempted that for you.
Nah, that's all right. I got my answer. So that's brilliant. I've also heard you mention somewhere that um, ketones are glucose sparing in the neurons. So that means that there's more glucose available to produce things like glutathione, etc., which will
Yeah,
decrease the
yeah, because there are
oxidative
some
stress.
pathways.
Yeah,
Yeah.
can you talk a little bit about that?
Again, it's probably a little bit above my technical level, but as you're saying, so
You
when
say.
ketones are present, there are certain pathways that require glucose, and we're very comfortable, I think, in the low carb space of saying, well, we are capable of producing our own glucose when we need to. There's certain cells that require it, and there's certain pathways within the nervous system that require it as well. So the pentose phosphate pathway is one, which is you were talking about. So and a lot of those are pathways that produce antioxidants and glutathione and other things like that. So if we're not using glucose for other reasons, if we've got ketones available to be an energy source and things like that, then it does free up the available glucose for the other necessary pathways that it's required in.
Okay. So basically we can say that our need for antioxidants is reduced when we are on a ketogenic diet.
Yeah, I
Is that
think that's probably true. Yeah.
yeah? Okay. That's very interesting as well, I think. Um, are there any other direct effects that you've seen from a keto diet that directly affects the chronic pain other than what you already spoken about? Which
I
is
mean,
a
I guess
lot,
there's
by the
all
way.
sort of secondary. I think I probably just about covered most of the things, but there's all those side things that go along with it as well. So we talked about
Yep.
the other significant findings that we had in the clinical trial being weight loss as being one of them. And so,
Mm.
when we think about the type of people that are coming in, or particularly to see me with chronic pain, so we work in a specific chronic pain program. So we're obviously getting people coming in that have had, long-term chronic pain. And if I'm looking at the people that are coming through the door, I would have to say that most of them have significant metabolic issues when they're coming as well. I'm not seeing somebody walk through the door who's fit and healthy and that, it looks the spitting image of health and all they've got is this rip-roaring chronic back pain. No, they're there and they've got, some depression going along there as well, and they've put on a little bit of weight, and, the doctors told them their blood glucose is getting up a little bit high and they're pre-diabetic and stuff like that. And when you look at the typical sort of person that has chronic pain, and again, this was one of the studies that I had to do for my PhD. I didn't mention it. The very first one that I did was a cross-sectional survey of 50 people with chronic pain, just to sort of, find out, what's the average chronic pain person like, and what do they think about their diet and whether they actually need to do anything about it. And, the funny thing was that, most people reported that their diet was great. But when I actually
I
assessed
was
their
gonna
diet, it
say.
was really quite poor. And the
Yeah.
average BMI was over 30, and there was an average of 3 comorbidities. And that matches up very nicely with I'm not sure if there's what we call the epoch data. So there's electronic data that's kept by all of the the chronic pain management centres throughout Australia and New Zealand, and they keep all sorts of statistics on this sort of thing. And the prevalence of comorbidities in people with chronic pain, I think 3 is the average between our two countries. So, when we're looking at what our diets can do from a pain management perspective, some of that improvement is going to come just by improving people's metabolic status and losing some weight as well, because the adipose tissue that we carry excess around our belly, that adipose tissue, it excretes inflammatory cytokines. So that's adding to the inflammatory load that we've got. And so what have we already said that ketones are great at doing? They're great at blocking inflammatory pathways. So if we're using ketones to block the inflammation a bit and we're losing a little bit of weight to stop producing that inflammatory response in the first place, then it's sort of a win-win when it comes to pain. So there's lots of side benefits when you look at the person as a whole by putting them on a low carbohydrate diet. So losing weight is just one of them. I think the mental aspects of it are really important as well too, and we see a lot of that it can really improve people's mood and perception of what's going on, because a lot of people, by the time you've got a established chronic pain problem, it's very rare you see anybody that's not also clinically depressed, because it's hard being in chronic pain all the time, and it sort of feels like you're in this helpless situation and you've tried everything and nothing seems to help and everything seems to make you worse. And so it does tend to be a big black psychological hole that you find yourself in. So so my work that I do, I work with a psychologist, and that's really important because the headspace side of things is really important. But if we can help people's headspace by their diet as well, then that's just another lever that we can pull in pain management that just helps the whole person and not just the structure that was the thing that everybody's looking at in the first place.
Yeah, and I think that's so interesting. So do you think that if someone is depressed and you can only treat their depression, would their pain levels go down just doing that and nothing else?
There's probably a good chance that would be the case, yeah, because all those things are inextricably linked together, and I think sometimes we like to put people in boxes, and you just want have a specialist for this thing and a specialist for that thing, and you forget to stand back and have a look and say, well, okay, well, this person is a whole person, and what's going on inside their head dictates what's going on in their body as well. And depression and anxiety and mood disorders are so commonly linked with chronic pain, and they're a two-way street. They feed off each other almost. And so if you've got somebody where the doctors have tried everything from a structural perspective and none of that helps their pain, but they've forgotten to look at the person's mental state. Well, that's really overlooking a big option of trying to help somebody, because if you can improve that and improve their outlook, then they sort of feel like doing a little bit more and they get a little bit more active, and so you can get a bit of wind on from that, from a different angle for the pain management. And so that's why when you're looking at pain management as a whole, we're trying to think of like how many different options have we got, what levers can we pull in this story. It's not just about pushing on a joint or stretching a joint that's the thing that was the problem in the first place. It's about having a look at, well, how can we help them from a psychological perspective? How can we help them from a metabolic perspective? How can we educate them so they actually understand what's going on, how they've gotten into a chronic pain problem in the first place? Because that's one of the biggest things when you look at the new research in pain neuroscience, is that if the person doesn't understand what's actually going on in their body and how they've ended up with a chronic pain problem in the first place, then that's feeding into the chronic pain cycle. Whereas if all you do is educate them to understand what's going on, and their brain can sort of go, oh, okay, that makes sense, you shift the balance of what's going on in how their brain is calculating the information that's being presented to it. And that in and of itself can help with pain management. So there's so many, different facets of pain management that we need to consider when we're trying to be holistic in helping somebody that's got a chronic pain problem.
So do you use things like I can't remember, is it called mirror box therapy or something like that you usually use with stroke patients or other people that have like lost their limbs and have phantom pains and that sort of stuff? Do you use
Yeah.
that?
So I do a bit with mirror box and those sorts of things, because when we think about somebody that's got chronic pain, so pain is this protective device that your brain, so it's a process within the brain that gives you an experience to make you do something. And that processing is an important part of the story of what's going on. So if we can change that processing, because up until this point in somebody's chronic pain story, their brain has been continuing to come up with the conclusion that things aren't great, things aren't safe, and so protection is required, and pain is one of the appropriate protective mechanisms. So what we have to do is we have to try and change that calculation within the brain to get it to come up with a different answer, to say, okay, it's not quite as bad as what I thought it was going to be, because that then helps us to then downregulate that excitability within the nervous system. And so if we can trick the brain, do whatever we can to get it to come up with a different answer, that's what we will do. And so mirror boxes is where that sort of fits into the story. So if you've got somebody that's, say, got chronic pain in one hand, if you cover it up with a mirror box and get them doing something with the opposite hand, to their eyes, what they're seeing is it looks like both hands doing the work, but the injured hand is not actually doing anything. So it's not actually sending any danger information potentially back to the brain. And it's almost like your brain goes, oh, hang on, that's different. That's not how it was. Maybe it's not quite as bad as what I thought it was in the first place. So there's a lot around mirror box and greater motor imagery and those sorts of things to try and change that processing pattern within the brain. Because if we're looking at the problem of chronic pain being it's a two-part problem. It's a little bit about the structures and stuff that were hurt in the first place, and they can always do with a bit of spit and polish. They can always do with a bit of stretching and strengthening and things like that. But it's far more about the problem that now resides in the nervous system, and that nervous system that's now sensitized that we've been talking about. That problem exists both in the nerves that come out to that body part, in the processing that happens in the spinal cord, and also the processing that happens in the brain. So when we're trying to change nervous system processing, we're sort of thinking about all those different places, and that's where you'll get, mirror box therapy coming into it. There's a lot coming out with virtual reality goggles and things like that, so trying to give different visual input that's disparate with what's actually going on in the body at the time. So there's a lot of ways that you're trying to essentially get the eyes to lie to the brain about what's going on and get it to come up with a different answer. So there's lots of cool research out there around that sort of stuff. And there's a really great TED talk by Professor Lorimer Moseley. It's a little bit old now. It's probably 10 years old or something now, but he's a really great larrikin and a good storyteller. But he talks about a lot of the experiments and things around pain science and trying to work out, well, what does the brain actually use to come up with this answer about am I safe or am I not safe, and how can we trick it, essentially. So it's a good TED talk. I think it's called Why Things Hurt.
Okay. See if we can find that link as well. So is there a way of doing this if someone has, neck pain or back pain or something like that? Because you can't really see that in a mirror. Is there a way of tricking the brain?
Yeah, mirrors really hard. Spinal problems, no, not in the same way that you can use it for peripheral joints and things like that. There has been some research using mirrors for spinal injuries where they've got them standing up, held up in a harness, and got they've actually put a screen in front of them and with somebody else's legs walking, so their eyes are seeing their legs actually walking and things like that. So there's all sorts of cool stuff out there. But no, mirrors are a bit harder to use for spinal things, although I did listen to a TED talk the other day, and I'm just trying to remember what the lady's name was. She's quite famous. She's got one of the most popular TED talks on. I'll find her name and I'll give you the link so that you can put down. She was interviewed by Dr. Chatterjee not that long ago, and it was called the high five rule that she used in the morning, and that was giving yourself like a high five in the mirror, and it's actually getting that physical contact with the mirror and the tactile response. Because normally, if you're in a team situation and you're giving your mates a high five and you get that sensation, there's certain cognitions and stuff that are related to that experience. And so looking in the mirror and seeing yourself, giving yourself a high five, it was like, committing to, I've got this today, I'm going to do whatever the things were that you were going to change. But I thought that's sort of interesting. You can almost use mirror boxing in that same sort of way with chronic pain, like giving yourself a high five in the mirror in the morning, saying, I'm committed to, doing this stuff that I need need to do today to try and help wind down that nervous system. So I usually, give that example to my spinal people, and they sort of look at me a bit funny about whether they're going to high five themselves in the mirror in the morning or not. But, there's lots of ways that I guess we can try and change, that visual input of what our brain is being told by our eyes, because it's such an important mechanism, like that mirror neuron idea. And a lot of the therapy we do when we're trying to get somebody to, get back into an activity that they couldn't do, we've realised that if you watch somebody doing that same activity, even though you're not physically doing it yourself, the motor, the patterning that turns on in your brain is almost identical to what it would be as if you were actually doing the task, but just not to the same extent. So if you've got a hyperexcitable neurotag, which is the term that we use for it, so every time you, like, I don't know, for example, you're going to bend down and touch your toes and you can't do it because your back pain's so bad, and you're thinking about, trying to bend down and touch your toes would, make you balk, then if we get you watching somebody else mindfully bending over and touching their toes, what your brain is doing, because our brains like to try and make sense of our world around us, and so to do that, it's almost like it projects us into the image. So it puts you into the place of the person that is doing the bending forward, and it gives that circuitry a little bit of a trial run to help your brain, help you understand what it is that they are doing. So if we've got something that you can't do yourself, if we can get you watching somebody else doing it and getting you to use some of that circuitry, but not to the same extent that's going to set off that hyperexcitable neurotag all the time, then we can start to desensitize it in a way that moves you back towards being able to do that task, and then getting you to mindfully imagine doing it yourself and running it through in your own mind, imagining that you're bending forward and touching your toes and it feels great and your back's not stiff at all and you feel like you did when you were, 18. Then that's also using that same circuitry. And it's stuff that, coaches have been using forever. If you think about the guy that's going to go and jump over the high jump at the Olympics, he doesn't just like wander out and then just run and jump over the high jump. He gets in his spot, and you can see him tracking that action through in his head a few times before he actually goes and does it. And what he's doing is he's giving that circuitry a trial run successfully before he physically attempts to do it. So it's increasing his chance of success, because it's not a surprise to the brain. It's already seen it a couple of times as a warm-up before he goes to do it. And so we're sort of doing the same thing with things that people can't do because of their pain. We take the activity that they want to get to somewhere down the track, and we unpack it back into smaller parts and get them practicing parts which in a way that the brain's going, yeah, I'm okay with that. That's not so bad. It's not so bad. And then you sort of sneak back in underneath the radar back towards the thing that they want to be able to do. And that way you're preparing your brain to be ready to do some of that stuff that at the moment, if you thought about doing it, it just wants to set off that pain response all the time, that learned pain reaction. So I guess it's a different way of approaching how you're doing things when you do have chronic pain, because we tend to do things the other way. We tend to sort of throw ourselves in the deep end and then fail. We decide, okay, yeah, my back's really bad, I'm just going to go down the gym and I'm going to, do whole exercises to try and get better, and you're starting to just makes you worse, and you walk away and you go, yeah, and your brain's going, yes, I told you so, that was a dumb idea. And next time you go to do that, I'm going to remind you. We're going to use that as a bit of evidence as to why that was a dumb thing to do. So you've got to change the narrative about how you're doing things to get your brain to come up with a different answer. And whether you're doing that through how you're doing your movement, or you're doing some trickery with mirror boxes and eyes and things like that, there's all sorts of ways that we can sort of do that now. But I guess you probably need a health professional to help you do some of that stuff. Sometimes it's not stuff that's necessarily the natural way that you would do things.
That's so cool. So what sort of things can people get help with if they come to your clinic?
So they basically hear me rabbit on like I have for the last little while. But I guess that's, what we do with people. So the psychologist and myself, we see people together, and it's very much sitting down and hearing people's individual pain stories, because the context around their stories and what's happened for them is the big determiner of why their brain has decided that this is a problem and why ongoing pain is an appropriate protective device. And usually there's all sorts of things in people's stories, whether it was, doctors back at the start told them they'd never get better and their scan showed, something terrible on it, and every time they try and do something, it just gets worse, and so they've given up. So there's all sorts of things around their pain story that then become part of the evidence that the brain pulls out subconsciously all the time to try and weigh up and decide, am I okay or am I not okay? So it really does, I guess, help if you've got somebody, you know, a professional that you can sit down with and work through some of that stuff, and I guess also get some education around, well, how does my nervous system work and why is it sensitive and how did it get that way and how am I going to do something different? Because what I'm currently doing is continuing to make that system sensitized. You've got to throw something different at it, essentially. So sometimes it does require, you know, somebody sort of helping you through that. But I guess there are resources out there. So Lauren Mimosy that I spoke about before with the TED Talk, he's got a book out called Explain Pain, which is something that a lot of people have used to go through and read to try and help understand and put it together for themselves. And he's got a thing called, they call it the protectometer, I think, and it's sort of like, they call it DIMS and SIMS, so it's danger in me and safety in me, and it's starting to try and work out your own story and all the reasons, you know, what's going on for you that has caused this ongoing you know, protective response. So there are some resources out there that you can sort of do on your own if you're interested. But I guess finding a clinician that's sort of up to speed with the latest neuroscience is the easiest way to get, you know, help for that sort of thing.
Yeah. So are there any people that you would say, no, sorry, we can't help you. You're beyond what we can do here.
That would be really dismal, wouldn't it? No, I don't think so,
Yeah.
because, you know, our system adapts to what you throw at it. And so if you've got a
Yeah.
really sensitized nervous system, we just have to figure out a different way of giving it information and changing the narrative for your brain. So, you know, we don't ever say to people, oh, we're going to 100% get rid of your pain and we'll have you back, you know, running in the Olympics. Definitely not. But if you've got somebody that's in just terrible chronic pain all the time, if we can at least get them back to less pain that's intermittent and lets them get back and do some of the things that they want to be doing, even though they might still have some intermittent pain, if they're back engaged in doing some of the hobbies and things that they enjoy, then their quality of life is a whole heap better. And I think, you know, that is a realistic expectation for most people from pain management. You know, the old school of pain management, you know, we used to have programs, and you probably had the same sort of thing over in New Zealand, where, you know, they'd send you to as an inpatient into one of the big hospitals for 2 weeks, and you'd see the, you know, the pain specialist, and, you know, see everybody, and they'd give you new medication and all the rest of it. And I guess the pervading ideology behind those programs was, yeah, sorry, we've done everything we can for you. You've seen everybody, you've had every intervention under the sun. We can't change your pain, so let's just teach you how to live with it. And that's not what the new neuroscience is saying. So if we really look at what the research says now, it shows us that no, you've got a nervous system that has adapted to become more and more sensitive based on the context of what's been going on for you. And it's a very realistic outcome to expect that we can move that away from being so sensitive and get it less sensitive, and thus your pain experience be less as well. So I guess it would be important to find, you know, people or, you know, practitioners that are very much versed in the new approach to doing things rather than the old school way of thinking, because it's not good enough just to tell people, oh, you just have to learn to live with it. That's not what pain management should be anymore.
Yeah, absolutely. Do you only see patients in the clinic, or do you work with people online as well?
We do telehealth as well. So we've got a clinic in Nowra, which is on the south coast of New South Wales, a couple of hours below Sydney. But we do telehealth, but I think we're probably limited to Australia, I presume. I don't know that we see people outside of Australia. Yeah.
Okay, that's good to know. So if people want to check you out, if they want to get in contact with you, where can they find you?
They can have a look at our website, which is, we don't update very often, but we have one which is just STEPP, so stepp.com.au, so solutions, tools and education for persistent pain. I do have a Twitter account, but I'm really, really bad at social media, so I don't put anything on there. So that would be really boring if you follow me, because I won't say anything very exciting, unfortunately. But we're happy for people to email us through our website if people want more information.
Okay. Awesome. Thank you so much for coming here today. Thank you so much for sharing your wisdom and everything that you've learned along this PhD journey, and also in your clinic, obviously, because chronic pain is something that I think most people as they age just live with, and it might not be necessary.
And they don't necessarily need to. That's right. It can be improved.
Yeah, so thank you so much.
My pleasure. It's been lovely chatting with you, Pim.
Thank you.